Dr. Flannigan. I'm a urologist at the Vancouver General Hospital, associated with the University of British Columbia. I'm also the clinical lead of the Prostate Cancer Supportive Care Program, Sexual Rehabilitation Clinic. In this video, I want to talk about setting expectations, sexual function changes following prostate cancer treatment. Prostate cancer is diagnosed amongst 1 in 7 Canadian men with similar rates worldwide. At the time of diagnosis, prostate cancer is localized to the prostate in approximately 75% of men and spread to other parts of the body or metastasize in approximately 25% of men. Treatment for localized disease may include active surveillance, surgery, including radical prostatectomy, or radiation therapy, which may include external beam radiation therapy, brachytherapy, or a combination of them with or without androgen deprivation therapy. For those individuals with metastatic disease, there's also several treatments available. This may include treatment of the localized cancer in addition to systemic therapy. Some of these systemic therapies may include androgen deprivation therapy, chemotherapy, other forms of antiandrogens, or a combination therapy of multiple of those. Fortunately, the survival for prostate cancer is 95% at 5 years, and due to this high treatment success, there's many prostate cancer survivors that must manage the potential treatment-related side effects. These are most often related to urinary symptoms or sexual side effects. Let's first talk about normal sexual functioning before we get into some of the dysfunction that may occur with prostate cancer treatments. In a typical sexual response cycle, we first experience the desire or arousal for sexual activity. This often leads to an erection, which with stimulation may lead to orgasm and ejaculation, commonly referred to as climax. Now, it's important to differentiate that orgasm and ejaculation are often used interchangeably, but they're actually two distinct physiologic processes. Ejaculation is the production of fluid coming out of the urethra, where orgasm is the sensation experience at the time of climax. Following this, there's often a period of resolution and a refractory period where it's both difficult to achieve another erection and to achieve an orgasm and ejaculate in this window. Now, one note is that you do not necessarily need an erection to be able to obtain orgasm or ejaculation. This can still be obtained with stimulation of a flaccid penis. Now, erections typically occur from thinking sexual thoughts or from sexual touch or in our sleep. Now, all forms of erections require a signal to be transmitted from the spinal cord through the pelvic nerves to the base of the penis to inform the penis that an erection should occur. When the penis receives the signal, arterial blood flow is increased in the penis and it's trapped in the expanding, spongy muscle, resulting in an erection. If you look at the diagram, the cross-section of the penis on the right is in the soft, flaccid state, and as the blood flow comes in and that muscle expands and traps that blood in, the penis expands in both size, length, and width, as well as adding rigidity for functional use. Now that we understand what's involved in normal sexual functioning, let's talk a little bit about how treatment for prostate cancer can have an impact on sexual function. If you look at the diagram on the right, you can see that the nerves designated in yellow coming from the spinal cord drop down adjacent to the rectum, behind the bladder, and along the shoulders of the prostate before going down into the base of the penis. Now, these nerves are critical for carrying that signal to induce an erection. However, they are very intimately involved on the sides of the prostate. So if you can imagine treatment with either radiation or with surgery, these nerves are at a high risk of being compromised or partially compromised during the curative intent of treating the prostate cancer. So with this nerve injury can then later result in cavernosal muscle fibrosis, or fibrosis of the muscle within the penis that's necessary to induce erections. If this muscle becomes fibrotic, it lacks the ability to maintain its elasticity and expand and trap the blood in the penis that's necessary to increase the penile size and rigidity during an erection. As a result, the erectile function may be diminished. Other mechanisms for erectile dysfunction after prostate cancer treatment is a compromise to the arterial inflow. Now, if we look at clinical side effects associated with the treatment, this may be erectile dysfunction, loss of ejaculation, change to orgasm sensation or pain, leakage of urine during sexual activity or during climax, shortening of the penis, curvature of the penis, decreased desire or sexual interest, and disruption to intimacy and masculinity. This can also result in relationship distress. To get a sense of what some of the sexual dysfunction is like amongst multiple treatments over time, let's look at this one randomized clinical trial called the PROTECT study, which was published in the New England Journal of Medicine in 2016. And really they did a good job of capturing some of the quality of life data amongst different modalities of treatment, including active surveillance, which doesn't involve active treatment, but very intensive and close monitoring, external beam radiation therapy with 6 months of androgen deprivation therapy that was performed leading into the radiation, as well as radical prostatectomy, otherwise known as surgery for prostate cancer. So here, over a 10-year period, they looked at 1,643 patients. And if you look at the graph on the right side of the slide, this is essentially a sexual quality of life measure from a validated questionnaire. The red line represents patients from the radical prostatectomy or surgery group. The orange line represents the radiotherapy treatment group, and the blue line is the active surveillance. So as you can see, everybody has fairly similar sexual quality of life at the beginning of the study, marked by 0.0. By 6 months after treatment, however, you can see that there's a significant worsening in sexual quality of life, and most notably in the surgery group. However, over the next 6 years, the lines tend to converge and arrive at a very similar point, which is still slightly lower sexual quality of life than when they began 6 years earlier. Now, we have to keep in mind that over time our sexual function may decline as we age, and very notably with our erectile function. Now, if we look specifically at the erectile function as reported by this study, they found that at baseline, 67% of these men reported that they had erections that were firm enough for intercourse. When they looked at 6 months following treatment in the active surveillance group, so those not undergoing localized treatment, 52% of these individuals were able to have erections firm enough for intercourse, 22% in radiotherapy, and 12% in the surgery group. If we expand that timeline all the way out to 6 years following treatment, now in the active surveillance group, 30% of these had erections that were firm enough for intercourse, 27% in the radiotherapy group, and 17% in the surgery group. This shows again that there's a slight difference in the surgery group compared to the other two, but compared to baseline over the same 6-year period, the erectile function declined in all of the groups and may also represent either pathogenesis of prostate cancer or just as simply an effect of the aging process. Now, here in this table is a summary of the different forms of sexual dysfunction amongst the different forms of treatment for localized prostate cancer. So if we look at the top row, active surveillance, so because there's not a physical intervention here, aside from PSA monitoring, sometimes MRIs and prostate biopsies, typically there's not an effect on the sexual interest or drive. However, if there is anxiety or stress associated with the cancer diagnosis and monitoring, this can have an impact on sexual interest and priority of sexual activity. Typically, there's not an impact on erectile dysfunction. However, again, if there is an anxiety or stress component, this can certainly play a factor. Orgasm, again, typically doesn't change, neither does ejaculation unless there's anxiety or stress present, and there is typically not issues with penile shortening or urinary issues. If we look at the second row, surgery or prostatectomy, if we're going to have symptoms, typically this begins immediately following the surgery. It doesn't often affect the sexual interest or drive unless there's stress or anxiety associated with recovery or the diagnosis. Changes to erectile dysfunction are immediate, and oftentimes there are not changes to orgasm. However, some people experience diminished sensation with orgasm or no change, and a small percentage actually experience heightened sensation with orgasm. Occasionally there can be some discomfort with orgasm as well. Ejaculation no longer occurs because the prostate and the seminal vesicle make up approximately 90% of the fluid with an ejaculate, and these structures are removed during the surgery, so therefore orgasm may be experienced when no fluid is produced. There may also be some possible penile shortening associated with a radical prostatectomy. There can be some leakage of urine during arousal or with climax, called climacturia. If we look at the radiation row, we see that the onset for sexual dysfunction tends to be delayed. The sexual interest or drive will decrease, especially if androgen deprivation therapy is given. Otherwise, it is similar to the other categories, only if there is a sense of stress or anxiety. Erectile dysfunction tends to be more delayed and gradual, but may begin as early as 3 months following therapy. And changes to orgasm may be experienced with some undergoing brachytherapy replacement of the seeds. Changes to ejaculation may occur. Some individuals may have decreased volume of the ejaculate, a dry ejaculate, or sometimes blood tinge to the ejaculate. Individuals may also experience some penile shortening, and there may be some urinary side effects on a more generalized basis throughout the days, and approximately 5% may experience leakage of urine during sexual activity. If we look specifically at androgen deprivation therapy, which may be combined with radiation therapy or on its own in more systemic forms of treatment, the onset occurs after testosterone levels have dropped down to near zero levels, and some of the side effects and symptoms may be progressive. So a significant decrease in sexual desire and interest certainly occurs in most men. There may be progressive and delayed changes to erectile dysfunction. Many describe decreased intensity to their orgasm, and there's often a decreased volume in their ejaculate. Penile shortening is also noted amongst many of these individuals. Now, let's take a closer look at the medical studies surrounding potential sexual side effects following surgery. Sexual dysfunction following surgery has been largely evaluated in the medical literature. Erectile dysfunction reports in literature are variable, between 20% and 90% in the surgical literature. Some of the factors contributing to postoperative function include baseline erectile function. So if you have good erectile function going into the surgery, there's a much higher chance that you're going to have good function coming out of the surgery as well. The surgical nerve sparing status is also really important. So if you have a bilateral nerve spare, that is the best case scenario in terms of preserving erectile function. Unilateral is still helpful, and if there's no nerve spare, if the prostate cancer was very involved and they couldn't spare any of the nerves to take out the prostate and potentially cure the prostate cancer, then that is the most challenging scenario, and erectile function recovery may be a little bit lower than the others. Patient age is very important. There's a lot of data to show that the older gentlemen receiving prostate cancer surgery may result in lower erectile function following surgery. Medical conditions are also really important. So several medical conditions can impact erectile function naturally over time. These include high blood pressure, diabetes, vascular disease, and heart disease. So individuals with any of these comorbidities may have poorer results in the future with respect to erectile function. Now, if we look at one series in particular, and this study looked at the impact of age on recovery of satisfactory erections adequate for sexual function. As you can see in the curve here, the left axis shows the probability of recovering potency of satisfactory erections, and the x-axis is the follow-up in months, between 0 and 60 months. As you can see, the lowest curve are those men over the age of 65, which have the lowest probability of achieving satisfactory erections, compared to the highest curve, which include those men under the age of 60 at the time of surgery. When we look at the preoperative erectile function status, we also see that those individuals that had full strong erections going into surgery resulted in the highest probability of achieving meaningful erectile function following surgery, approximately 60%. Those that had a recent decline in erectile function just leading into surgery had slightly lower postoperative function, and those that didn't have great erectile function going into the surgery had the lowest recovery postoperatively. If we look at the impact of surgical nerve sparing status on post-op recovery, as you can see, again, the top curve, bilateral nerve sparing status, carries the highest chance of recovering postoperative satisfactory erections, followed by unilateral nerve damage, followed by unilateral nerve resection. Following surgery, erectile dysfunction typically occurs immediately after, but may even decline to an ultimate low around 6 months postoperatively. There's several theories about why this may happen. As we understand it, the initial insult to the nerves results in immediate change to the erectile function, and over that initial period of time with the injury to the nerves, we see increased inflammatory mediators promoting fibrosis of the penile muscle, which likely results in additional impact to the erectile function outwards of 6 months. In one series, when they looked at all the men undergoing radical prostatectomy, and they looked at 4.5 months postoperatively, about 25% of these had enough erectile function to have satisfactory erections. By the time 30 months postoperatively, approximately 50% of men had recovered satisfactory erections. Now, if we look at a subgroup of these men from the study, and if we only include all of the men that had recovery of satisfactory erectile function and then look at their timeline, what we see is that 25% recovered satisfactory erectile function by 1.5 months postoperatively, 50% recovered good erections by 4.5 months, and 75% by 12 months. We think that recovery of the nerves and regeneration occurs typically within the first 2 years following surgery, but some studies have suggested that this may even happen to a small degree upwards of 4 years postoperatively. Some of the other forms of sexual dysfunction beyond erectile dysfunction following surgery includes urinary leakage, such as climacturia or arousal incontinence, which affects approximately 30% of men, and approximately 47% of these men are actually bothered by it. Painful orgasm, also called dysorgasmia, may affect between 3% and 18% of men following surgery. It's more typical in the earlier phases postoperatively, and if it does occur, it is localized to pain in the penis in approximately 63%, pain to the rectum in 1/4 of them, pain to the abdomen in 9%, and 4% were described in other regions. When we characterize the pain that these individuals discuss, 55% of them have pain lasting less than 1 minute, and 2.5% lasts greater than 1 hour. The pain with orgasms tends to decrease over time. If we look at altered orgasmic sensation, this may occur in some individuals. Up to 37% of men complain of no orgasm, 37% of men complain of reduced pleasure with orgasm, and interestingly, 4% of men reported enhanced pleasure with orgasm post-surgery. What about penile shortening? There's been a lot of reports several years ago that suggested men may lose up to 15 to 20% of penile volume postoperatively. This was thought to be due to penile muscle fibrosis and loss of elasticity within the penile muscle, but the exact mechanism is largely unknown. There's been a more contemporary study that was recently published, and what they found was that they did identify penile shortening up to about 2 centimeters 10 days postoperatively. However, when they did an MRI approximately 1 year postoperatively and measurements, what they found was that the penile length actually had returned to their baseline status. Penile curvature has also gathered some attention, called Peyronie's disease, when it's acquired later in life, and this has been identified in up to about 16% of men being evaluated for erectile dysfunction. Some of these are prostate cancer survivors. And some of the thought of how this may occur is that as the muscle is accumulating some fibrosis with the changes after surgery, this fibrosis may also extend and initiate scarring and fibrosis and plaque formation to the outer layer of the penis called the tunica albuginea, which is kind of the casing to the penis that contains all of the muscle. And normally this layer has to be elastic and expand both in width and length to accommodate the changes in the muscle. But if there's scar tissue in this layer, then that section is no longer as dynamic and results in a shortened segment, which also results in curvature or penile deformity. Now let's take a closer look at some of the medical studies surrounding potential side effects following radiation therapy. So if we look at some of the biological implications of how radiation therapy can impact erectile function in individuals receiving treatment, what we know is that it negatively impacts the pudendal artery function and tone. We also know that the nerves can have an impact, and there's axonal degeneration of the cavernous nerves. This results in a decrease in the signal going to the penis to stimulate oxygenation and smooth muscle relaxation, which are both necessary for erections. This results in progressive cavernosal muscle fibrosis and venous leak erectile dysfunction. The majority of medical literature focuses on erectile dysfunction. There's huge variability in the rates of erectile dysfunction similar to surgery, and there's rates published between 6% and 84% erectile dysfunction for external beam therapy, and between 0 and 51% for brachytherapy. If we look at a meta-analysis, so a study looking at the results of multiple other studies published in the literature, we see that 26 to 55% of erectile dysfunction occurs at 60 months following therapy among men who had previously functional erections, which is important to denote. So why is there so much variability in the literature and the numbers? It'd be much nicer if we could provide one concrete number of what to expect, but unfortunately the medical world is so complex with different factors of patients, it becomes challenging. Some of the reasons for this is that patients have different medical conditions and comorbidities competing to decrease the erectile function. Similarly, patients have different baseline erectile function going into treatment, which has an impact on the post-therapy outcomes. The age of patients, as we previously discussed, has a large impact on erectile function over time. The type of radiation therapy given can have an impact on this, as well as the dose. If adjuvant or the addition of androgen deprivation therapy can also have a significant impact on this. It also depends how we're measuring erectile function. There's multiple questionnaires and validated tools that we commonly use to measure erectile function, and it just depends which one of these tools we're using as it captures the information slightly differently. It depends at what time points we're measuring it based on the impact of radiation therapy has on the erectile tissue and the nerves. And it also depends if we're capturing patients that are using erectile aids or not. So the erectile function of an individual following radiation therapy might be very different if they're not using any therapy compared to if they're using pills such as Viagra or Cialis, compared to using injections or vacuum therapy. So when may difficulties with erections occur following radiation therapy? Typically may begin as early as 3 months, but tends to be the worst somewhere between 24 and 36 months following therapy. However, there may be some progressive decline in erectile function as we age as well, which is common to all of these forms of treatment following prostate cancer. What are the predictors of erectile dysfunction for radiation patients? Poor baseline erectile function prior to the treatment, increased age, higher radiation dose, other health problems or comorbidities contributing to erectile dysfunction, such as high blood pressure, diabetes, vascular disease, heart disease, and concomitant use of androgen deprivation therapy. So a lot of the same factors that are also risk factors for the surgical patients as well. So now let's take a closer look at the medical studies surrounding potential sexual side effects following androgen deprivation therapy and the importance of testosterone in normal sexual functioning. So how can testosterone impact sexual function? Well, we know that testosterone acts centrally in numerous regions of the brain and spinal cord and drives male sexual behavior related to desire, ejaculation, orgasm, and erections. We also know that testosterone is neuroprotective. We know this from studies in the lab where they decrease testosterone levels to near zero levels, and this results in impaired cavernosal nerve function and structural changes to the penis, where we see increased levels of fibrosis and scarring. Testosterone and other androgens also maintain the penile muscle structure and integrity, and absence of this testosterone results in fibrosis. Testosterone also supports endothelial function, which are the cells lining the inner vessels. Largely, it supports nitric oxide and cyclic GMP function. So if we look and bring this back clinically, what we see is that in men undergoing androgen deprivation therapy, there's a significant reduction in sexual activity, between 55 and 20% reduction. These individuals have an increased frequency of erectile dysfunction, reduced frequency and strength of nighttime erections. Typically we have 5 nighttime erections per any given night, and these individuals will have fewer, and if they do have erections, they be much more blunted. There's a reduction in sexual desire, and this increases by between 25 and 40% amongst survivors with ADT. Many experience reduced ejaculate volume as well as decreased orgasm sensation. Just want to take this opportunity to thank all of our supporters for the Prostate Cancer Supportive Care Program. The Specialist Services Committee provided funding to help us initiate this program in January of 2013, and more recently the Ministry of Health has provided funding in 2017 that allowed for the provincial expansion of our program to reach more British Columbians with sexual dysfunction and survivorship issues following prostate cancer. I would also like to acknowledge all of the other agencies that have supported our program throughout the years, as well as the individuals and families that have provided generous philanthropic support. If you'd like to look more into our program or connect with us, here are our contact details, including our email, website, Twitter, and Facebook programs. Thank you.